Thank you very much to the organizers for inviting me today to speak on pediatric manifestations of COVID-19. Clearly, this is a long topic to be able to give 15 minutes credence, but I hope to be able to hit some of the highlights of some of the issues that pediatricians across the world are otherwise dealing with over the course of the pandemic. I have no disclosures. In February 8th, we got the initial representation of the 135 pediatric cases that were coming out of China. We found two big specifics from this initial case report. The first is that, as you can see from the charts over on the right, there was significant spread of this disease that happened just in weeks' time, very much overtaking and showing the contagious factor of this among children. We also found that there was only severe symptoms represented in about 5%. And some of the symptoms that people were talking about were hypoxemia, dyspnea, and of much more interest, GI maladies. That is not something that we typically see with higher rates in other viral illnesses, but was something that we were noticing in this novel coronavirus. Critical symptoms, i.e. need for mechanical ventilation or ARDS or even myocarditis, was present in less than 1%, and China reported on only one death. Of also interest is that infants under 1 were found to have the highest rate of critical symptoms, but a significant portion of moderate symptoms were seen in older kids, not a factor that we usually see with normal circulating respiratory viruses. In 2020, the Chinese National Clinical Research Center put out some kind of thinking points about this that they were seeing based on the initial cases that they were identifying in their country. First of all, some of these have now continued to hold true, where we have an incubation period that appears to be about 3 to 7 days and can affect children of all ages. We understood that concern that most of the spread was occurring from adults to children as opposed to the opposite, which is what we typically see with influenza. We noticed that asymptomatic children can spread. We also noticed that respiratory droplets and prolonged close contact seem to be the main transmission course as opposed to contaminated surfaces. Most patients seem to recover within 1 week, and no newborns at this point were actually delivered to COVID-positive moms, a fact that still remains to be true, that it is unlikely for newborns to come down with illness to COVID-positive moms. But the authors concluded their statement that there was still significant unknowns with this, and that SARS and MERS epidemics did lead to pediatric death. And though we are seeing much more mild or clinical symptoms, a lot more research was needed to be done. Not surprisingly, as we all know, this really framed how we think about other countries. In France, the spring of 2020 found that they were reporting out on a significant spread of disease throughout their country. 11% of their hospitalized patients were severely ill. 1% of them, and less than 1% of them, have died. They identified a couple of factors at this point that were associated with severe severity, which was age over 10, hypoxemia at presentation, and a high CRP. While if you can look at the charts on the left, there was a high proportion of infants that were getting admitted, most of those patients did okay. And we were probably admitting a lot of them, maybe even potentially unnecessarily so. However, the patients on the right, the ones that were older than age 10, the teenagers, were the ones that were appearing to be a little bit sicker. Again, a fact that we were finding is not necessarily true when we deal with other circulating coronavirus, but really any other circulating respiratory viruses that inflict on pediatric care. Italy also demonstrated the same function. So May of 2020, Italy had the second highest number of total COVID-19 infections in the world and the highest death rate at the time. Children at the time, probably because of lockdowns, only composed about 1% of cases, though 11% of their childhood cases led to actual hospitalization. They found very similar findings, is that while only 4% of patients developed severe disease, there was a little bit of a predominance in severe disease in the infant age, but they were still very surprised at how many older kids were presenting to the hospital. In the United States, we found very, very similar findings. So if you remember, the United States was hit hardest in the Northeast, and so a lot of our initial data came out of New York. This is from Cohen Children's, which is just outside of New York City, that described their first 65 patients. And they were one of the first to see a large predominance in older patients, 12 plus, as demonstrated by the graph over on the right. They noticed that fever was present in a high proportion, it was 86%. Lower respiratory symptoms in about 60%, and GI symptoms, again, this is among hospitalized patients, was present in almost 2/3. 34% of patients required some degree of respiratory support, although a much lower portion required actual intubation. Only 5 patients needed to be intubated, a pattern that we still see to this day. Severity was lowest, again, lowest in infants that were less than 60 days. but it was highest in those with chronic illnesses, and they noticed one death. This is a pattern that has continued now, where we noticed that infants, while we were admitting them in high numbers, probably weren't getting nearly as sick as the teenagers. And the teenagers that were getting sick were ones that clearly had other chronic illnesses and comorbidities. The CDC in the United States took this on and tried to look at the first 2,500 cases that were seen in this country. This is all cases, not just hospitalizations. And if you look at the graph on the left, they found a much more higher percentage of patients that were getting it that were above age 10, probably because they were a little bit more out and about. But a higher percentage of those patients were actually getting ill compared to the younger infants. They also found the significant amount of neonates that were having some problems, but still found a surprisingly higher rate of individuals that had problems with being much older. If you can see by the initial part of table 1, a lot of these patients were presenting with fever, cough, and shortness of breath, but there was still a high proportion of individuals that were coming with GI complaints. When we look at the risk factors for death in this population, this is pooled data from the CDC. We noticed that there was 74% of all deaths were occurring in Black and Hispanic children. Some of this was much more specifically because of the genetic predisposition of those individuals, but others was also because of the inequities that we were seeing in the country and still are seeing in the country at this time. There was a large male predominance factor that continued, and 86% of them had one underlying medical condition, of which obesity, asthma, and developmental disorders was seen to be one of the higher things that was otherwise known. If we then look and go at what was the risk factors for severe infection, so this is in patients under 21 years, what are the risk factors for severe infection? You can see a similar and surprising finding. Look at the top part of this graph. Infants under 6 months and 6 to 23 months were less likely to develop severe infection compared to the teenagers. Those that were 10 to 12 and upwards of 17. Also, greater, if you go to the bottom of this, greater than one underlying medical condition entailed one of the biggest issues and risk factors for problems. And so a lot of times in infants, it was chronic lung disease and neurological disorders. But in older patients, it was obesity and diabetes. So factors and patterns that would now started to be introduced to other parts of the country are now being seen here. Finally, we also were surprised at how much of these patients had myocardial involvement and were presenting with myocarditis. Now, viral infections are a known cause of myocarditis in pediatric patients, and we typically see them in the Coxsackie viruses, but also other enteroviruses that circulate routinely in this country. But we also see it significantly with influenza. During the initial surge, there was almost 729 admissions, which was believed in pediatrics to be a vast underestimate in patients under the age of 24. This was a 50% increase of normal myocarditis that was seen in the years prior. Male predominance was found to have the risk of myocarditis was almost 16 times as high among patients with COVID-19 compared to without. The data is a little bit unfair because we also saw a significantly reduced amount of other circulating respiratory viruses that was occurring at the time. But still, this result was much more profound in children, where a risk of COVID myocarditis was 36 times as high as those patients who did not develop COVID. So we knew that we were seeing a significant myocardial involvement related to patients that were getting hospitalized with acute COVID. Furthermore, it's also not surprising that during this time we would have issues with post-viral inflammatory syndromes. Now, post-viral inflammatory syndromes are seen with other circulating viruses, both in the United States, Europe, and in Asia. And in April of 2020, the UK reported a series of 8 children that had a very bizarre appearing post-viral inflammatory syndrome that looked like something called Kawasaki's disease. But the problem is that it also developed features of toxic shock syndrome. All of these children had unrelenting fever, upwards of almost 40 degrees Celsius. All had variable rash, conjunctivitis, peripheral edema, and extremity pain, and many of them had significant gastrointestinal symptoms. All of these children had previous SARS-CoV-2 infections or known exposure to the disease weeks ago, and all of them had resolved. Now, again, this was a signal that people thought we were going to see a high likelihood of Kawasaki's disease, but it became very apparent that this disease looked very, very different from Kawasaki's disease. And why was that? Well, the UK expanded on their initial group and found that across PICUs across the United Kingdom between April and May of 2020, there was a higher rate of these patients starting to develop. Now, at the time, we were calling this pediatric inflammatory multisystem syndrome temporally associated with SARS-CoV-2. It was a bit of a mouthful, and you can imagine why this disease is now being called multi-system inflammatory syndrome of children, or MISC, a little bit easier to talk about. You can notice that there was a significant increase of this. There was probably a mix of what was considered true MISC and what is actually more COVID myocarditis in this group. But this was some of the first description of the therapeutics, including steroids and IVIG, as well as some of the biologic and antiplatelet medications that were being utilized. We saw an aggressive amount of this in the United States as well, and we kind of identified now that these patients developed a very specific pattern. So a history of very mild COVID, followed 3 to 4 weeks later by profound cardiac findings, which is not seen oftentimes with Kawasaki's disease, plus or minus coronary artery involvement. Patients were profoundly thrombophilic, had GI discomfort and arthralgias, and very few of them ended up with respiratory insufficiency compared to what we saw with acute COVID pneumonia. There was also a very specific laboratory finding. These patients were lymphopenic and anemic. They had very high rates of inflammatory components, including CRPs, ferritin, and sed rates that were very elevated. Their pro-BNP was very elevated. And the initial descriptions talked about a troponin bump, but I think a lot of this was probably being mixed with COVID myocarditis. And now we don't really include troponin as a significant elevation when we talk about classic MISC at this point. The epidemiology, which also differs significantly from Kawasaki's disease, was much higher in the 5 to 11-year-olds and the 12 to 15-year-olds. Kawasaki's disease tends to be a disease of under 4. There was a high male predominance, and 60% of those patients identified as Black or Hispanic. The post-viral inflammatory conditions have known genetic predisposition, but we didn't know if this reflected COVID-19 infection patterns or an abnormal host response at this point in the pandemic, and we really still don't know fully. We also noticed a significant temporal relationship. And so you can see on the dotted lines here that as COVID-19 cases rose, it was followed precipitously about a month later with rise in MISC. We haven't seen that to the same degree with this Delta variant, but I think a lot of us would agree that the data is still a little inconclusive about whether or not we're going to see high rates of MISC following the Delta surge in many parts of the world. Thankfully, a lot of these kids do pretty well. And so this was a single center experience of patients following up with MISC. A lot of them got IVIG, aspirin, and methylprednisolone, but you could see there was also a role for anakinra and tocilizumab in patients that were being treated. And you can notice that by 8 weeks, all 48 individuals in their group had returned normal coronary size, resolution of any coronary aneurysms if they were seen, and a return of their normal function. This was also seen in their inflammatory components, where their CRPs went way down very quickly and their pro-BNPs went way down very quickly, noticing a very rapid resolution of their inflammatory components. This was mirrored in the UK. And the UK showed a very, very quick resolution of cardiac dysfunction and otherwise a normal return of their aneurysm development. The US has launched a large 33-site study looking at this, and we're enrolling 900 patients. And so there's going to be a lot of information coming out of this in the coming years about how this overall affects children going forward. So we will see a lot coming out of the music study with what we think about, but we're otherwise reasonably pleased at how well otherwise kids do with this condition. Finally, I'm going to conclude with the effects on pediatric mental health. And I think this is a very important part to leave you with. In Texas in 2020, they noticed a significant increase, as indicated by the dark bars, compared to the light gray bars in suicide attempts in emergency rooms compared to 2019. The CDC got very interested in this. And so they published data looking at the National Surveillance Program between 2019 and 20 and found, based on that dotted line and dashed line, there was a significant increase in mental health related ED visits. While total ED visits were down, the proportion of them that were mental health related rose significantly in 2020. And perhaps even more harrowing with this was the effect that it had on suicide attempts. And so you can see as the dark long bar lines that suicide attempts were increasing in this country through 2020 in young adolescent girls. But then the much more concerning one is this dark solid line, which has shown what has continued to happen to those into 2021, where we have seen a 50% increase in suicide attempts in young adolescent females. There is significant concern that this is going to lead to a higher rates of death related to suicide alone than what we saw with true COVID disease and the medical issues that come from that. But completely underlies the rate of that. It's important to understand the public health initiatives and public health concerns that have happened related to pediatric mental health during the pandemic. Thank you.